some troubles, but comparing with periodontitis and some of our perio cases, this is of course nothing. So late, and we hope that we will compensate by giving you some good inspiration for future clinical work. Thank you so much for waiting for us. A little bit of a struggle with this presentation. Now, I'm going to share my expertise when it comes to periodontal and peri-implant care. I'm Caspar Wohlfahrt. I'm a specialist in periodontology. I am also an associate professor at University of Oslo. I share my time between clinical work in my private practice, research at University of Oslo, but also as head of research and development at Labrida. So I'll try to give you as much as possible of my knowledge within this field today in this presentation. Eager to hear your comments afterwards, questions and so on. We are also next week going to EFP in Vienna, so hope to see many of you there. Now, as you can see here, this is my workplaces, my clinical work in my private practice, sharing that also with the faculty in Oslo. Started my career as periodontist at University of Minnesota, graduated in 2004, and at that time point we did some very early periodontitis cases. No one really believed in it, as you may remember. So I'm starting to have some years behind me, and still remember the difficulties kind of getting people to accept that periodontitis was a new disease entity. But now I think we can all appreciate or know and understand the trouble that this disease is causing. So these are some of our cases. Still loads of referrals of periodontitis cases. I, in the beginning, through my research, asked for cases and ended up, of course, getting a lot of periodontitis cases. I'm still doing. Me and my friends at the faculty also are certainly getting a lot of periodontitis cases. And the clinical problem is certainly there. We know, based on asking implant companies and trying to figure out numbers ourselves, that as of today we have about 70 million dental implants in the world, probably more than that, but this is known implant cases. So difficult to get those numbers exact. We know also from studies about 20% of those implant cases will end up with periodontitis after 5 to 10 years of function. So the problem is there. Now we need to find ways to solve it. And that was kind of the background when I started my research back in 2004 in Oslo, and ended up basically understanding that there's no such thing as a predictable solution for periodontitis. So I changed my focus working with implant care, maintenance, trying to avoid the problem instead of trying to solve this hopeless, sometimes at least hopeless situation. It will never go away. This is a sign I found down in Spain like a year ago or something, and that I think relates clearly to our friend, or what shall we say, enemy, periodontitis. It will never go away. We have to live with it. Implants is still a fantastic solution for many of our patients, but we need to realize that we need to try at least to avoid problems, and help our patients to stay healthy. Now, expectations. This is something I like to talk about. We say at the office that never overpromise and underdeliver. That's something I think you should live after as a rule. I try to do that. Don't promise too much when it comes to implants, period treatments, what else. Try to give your patients realistic expectations. That might certainly, the best one of the best ways to avoid problem afterwards is certainly to give your patients realistic expectations. Treatment planning phase. So this relates all the way back to when we place our implant. We start planning for our implant cases. We in our clinic we also certainly place a lot of implants, but we are at least trying. We're not optimal. We're not not perfect, but we are at least trying to inform about risks and for periodontitis after 5-10 years. We also inform about the importance of maintenance, and of course certainly ascertain that our patients are as healthy as possible when it comes to periodontitis, avoiding smokers and such, prior to promising the patients that we shall give them an implant. So that or no more. Again, important, never promise that an implant will be better and easier to take care of than a tooth. This is something that you certainly know, all of you, and also that we try to live after when we do our clinical work. An implant is a man-made replacement for a natural tooth. I like this statement by Klaus Lang, which we also try to keep in our spine on an everyday basis. All implants are not replacing teeth, they should replace missing teeth. Klaus Lang, 2007. So that's something that, remember that, try to thoroughly think about this statement. A missing tooth, then an implant might be a good solution, but to replace teeth, potentially not such a good solution. An implant is a poor replacement for a tooth, but can be a good replacement for a lost tooth. Put that in your frontal lobe and live after that on an everyday basis, especially when you plan your cases and you talk with your patients. Sometimes we have to extract teeth for technical reasons, but certainly avoid extraction of teeth. There are now more and more and better treatment solutions when it comes to saving teeth. So we should try to remember that on an everyday basis. Never promise that the periodontitis treatment will be 100% successful. There's no science to support such a statement. The treatment may or may not help. I'll come back to that a little bit later in this presentation and discuss the alternative prior to initiating the treatment. So always discuss with your patient, never overrule your patients, discuss different treatment solutions. You all know this from your clinical daily practice. And again, which I really want to try to pinpoint today, always inform the patient about the importance of lifelong implant maintenance. This is crucial. So based on the literature, based on what we know today, and again, back to this, avoid the problem, avoid periodontitis as much as you can. I want to share two patients. This is a very old patient of mine treated in the States when I was a very novel perio resident. Aisha, she has advanced gum disease, and she is shared in this presentation with Ingrid, which was one of the very first periodontitis cases I treated and I really struggled with in Oslo, together with my department head at that time point, Anne-Mette Ås. So these are two cases. We'll try to see how we solve the problem. Now, Ingrid, she was a very advanced case. At that time point, I had thought that all teeth of hers should be extracted and replaced by implant. Young and eager as I was to place the implants, that has changed quite dramatically through the years. But she never received the implant. She maintained all her teeth. I will show you what we did. Now this is Aisha. She had open flap debridement surgery, certainly a very advanced periodontitis case. Kind of, what shall we say, a little bit over the top as a very young periodontist to see something like this. I had also expected that she should lose all her implants. The problem with for this patient is that if she loses the implants, it's going to be extremely difficult either to replace them or even give her a full denture based on the resorption of the alveolar process. So this is what it looks like. She loses the implant. Took me about 3 hours to remove the superconstruction, since all the screw holes are filled with fluid composites. So that's not such a good idea. Make sure that you have a retrieving possibility. Use screw retained solutions. All of you know that, but please keep that in mind on an everyday basis. Avoid cement retained superconstructions. So these are the lost implants. She maintains, keeps 5 implants after the surgery, and of course I expected that she should lose all of them. Now this is Aisha after 12 months. She was very, what shall we say? She had had very little dental treatment before, and took me quite a long time after thorough and hopefully at that time point quite qualitative scaling and root planning. She reduced her pockets down to between 1 and 7 millimeters from initially up to 11 millimeters, 10 to 11 millimeters. She still has some plaque, but minimal now. She has really changed her habits, cleans her teeth. She was never a smoker. She has diabetes. She's put on a recall program on a 3-month basis. From me expecting that she should lose all her teeth to a patient purely treated non-surgically. Of course, extremely nice to see as a young periodontist how much we can solve truly only through non-surgical treatment. Now, this is Ingrid after 12 months. She has maintained 5 ovary implants. Her pockets are reduced from 7 to 10 millimeters, and she's now down to 1 to 4 millimeters of pockets with very little bleeding. She's a much happier patient, no pus, no minimal bleeding, and she has the possibility to clean her implants on a daily basis. And 2 quite old patients, and we have maintained those patients both at University of Minnesota through my colleagues over there and also here in Oslo. So they have managed to keep both teeth and implants in a long-term perspective, a long time after the initial active treatment phase. Now, this is again Ingrid in Oslo, 8 implants, and after 12 months, 5 implants. This is again the clinical situation with some bleeding but very limited. This is Aisha at the 9 years control with my good friend Leo Batas down in Thessaloniki now, also a student of Minnesota, and Lisa Durkot on the right side, which is the hygienist that maintained Aisha every 3 months. So the reason for the result is certainly possibility to give the patients infection control. Ingrid at 2013, 7 years control through 2 of our postgraduate students in Oslo. Again, limited pocketing, and she has managed through the good infection control to maintain her implants. She ended up in a retirement home at old age. So now it's of course a struggle for the staff there to keep things healthy, but at least we know that she saved the implant from the initial situation when I had thought that she should lose them 7 years or hopefully even longer. So did I do my patients a favor? Yeah, we hope so. We maintain both teeth and implant in quite an easy fashion. When it comes to the teeth, only scaling and root planning. When it comes to the implants, again, 1 surgery and thereafter maintenance. What's the reason for it? Yeah, stop and think. Remember this. This is basically and purely a matter of achieving optimal possibilities for oral hygiene for the patients. We managed to make sure that the patients could clean. Of course, we reduced the calculus deposits and so on and so forth. We made sure that the superconstruction and the implants were seated properly, certainly, and also gave Ingrid access for oral hygiene. So improved oral hygiene and improved possibility to perform oral hygiene is the hallmark here. Again, regular maintenance with continuous focus on infection control. Combination of professional cleanings, very important, and also the self-performed oral hygiene on a daily basis. This is Ingrid at the 12-month control. We feel that we have really helped her to accomplish the need for oral hygiene. Of vast importance. Start with this already at day 1 when you plan your patients. Discuss with your technicians. Always make it possible for the patient to clean their teeth and implant. Prevention, of course, that is what my major research focus is of today, and also what's going on in my mind on a daily basis. Avoid problems. I guess we have done sufficient number of surgeries to realize that if you can avoid such situations for our patients, that will make their life much better. And we are, of course, extremely busy anyway, so we feel that we should try to avoid the problems as much as possible. So can periodontitis disease be prevented, and can we improve the long-term results of treatment? We hope so. If you look at Costa and coworkers, this is a very classic study. I'm sure that many of you have read or at least seen this study before in presentations. Costa in 2012, he showed, based on 80 patients, 5-year follow-up of 80 patients, 2 groups, one which was dropouts without peri-implant regular maintenance, various types of maintenance. Again, the other group which were consistent and cooperated with maintenance and didn't drop out, 41 patients. So the patients that did not drop out, and this is very important, I think you should keep this in your mind. When your patient asks you, is it really necessary that I come in on such a regular maintenance after the implant placement, then you could use this publication, at least for yourself, to give yourself some self-esteem when it comes to keeping your patients on a tight leash with maintenance, using your dental hygienist or your do-it-yourself. My clinic, I've got 4 dental hygienists that maintains both our perio patients and our implant patients. So the follow-up period was 5 years. He demonstrated clearly that regular peri-implant maintenance care prevents development of periodontitis. 43.9 periodontitis in the group of patients with no maintenance versus the maintenance patients that cooperated with maintenance were around a little bit less than 20%. Still a high number, but of course much less if you don't if you're not in the maintenance program. So this has been studied further. This is studies by Rocuzzo, now a systematic review of Rocuzzo in 2019. Other publications also included in this systematic review, and again Heights Mayfield, Lisa Heights Mayfield in Australia. Also a consensus meeting where she reports periodontitis treatment should be followed by individual supportive care. Now Rocuzzo therapy of periodontitis followed by regular supportive care resulted in high patient and implant level survival in the medium to long term. So maintenance is key to a stable long-term result. On an everyday basis, when you plan your cases, keep this in mind. Don't leave your patients on your own after you're done with the implant treatments. And also let them know this at a very early phase. This is Labrida BioClean. We're going to talk about Labrida BioClean a little bit today. This is my invention, which I would like to share with you. Some of the new thoughts also in the end of this presentation. I hope you will stay with us, even if we're late with the starting point. Now, this is an oscillating brush. I'm sure that many of you have used it already. Very happy for all our followers and all our clinicians using this brush both in Scandinavia and the rest of the world. Now, this is a patient, an animation of a patient with advanced gum disease, advanced periodontitis. With periodontitis, mild periodontitis, as you can see here. As you can see, this is just to show you how the brush is used in the clinical situation. So quite mild periodontitis. The brush is a maintenance device. Please remember that. So this is, of course, a case with some early bone loss. For advanced cases, we need usually surgery. I will show you some interesting cases also when we use the brush for more advanced cases. So the probing moment, working in an up and down fashion, irrigating the pocket afterwards with sterile saline. The brush is made of chitosan, so the leaving particles or remnants of the brush is not a problem as compared to other type of devices. So the brush has been used in now close to 150,000 cases throughout the world. So we feel that the response is good. The clinical studies are there. And we hope after now 13 years on the market that this is something that you find useful on a daily basis. Now, Why chitosan? Chitosan is a very interesting material. I have done a lot of work on chitosan. I had the aim to find a material for the bristles that did not cause inflammation and did not leave remnants, and which did not hurt the implant surface, since the brush is going to be used on a 3 months basis. It's biocompatible and safe. It's resorbable, causing no remnants in the pocket. Basically, chitosan resorbs as sugar. It's gone after about 48 hours. We have shown this in our experiments, specifically now, since we just recently submitted an FDA approval, and then also now, both now and previously, we have done our homework when it comes to really demonstrating that this material is safe. And it's gentle. When you wet chitosan, it soaks water, swells, and becomes soft, doesn't cause, which makes it not causing any harm to the dental implant surface. This is the first paper I found very long time ago when I was looking for various types of resorbable materials. This is a study from Tokyo University, where they use chitosan sutures with chitosan as in the filaments, and Nakajima and co-workers demonstrated that yes, it might work, but still the material resorbs a little bit too fast. So certainly optimal when it comes to a cleaning device. But again, they managed to manufacture sutures of material, which was the reason why I managed to find filaments for our brush. This is the brush, as you can see, with the blue filaments made of chitosan, used for professional care. Unique in its design, and also the only instruments actually that is when it comes to brushes that doesn't leave any remnants. The patent tells you that this is the instrument of choice when it comes to subgingival instrumentation of an implant. If you want to avoid either scratching the surface of the implant or avoiding leaving remnants. A CE-marked instrument, which is of course vastly important when it comes to doing this type of advanced treatments. Any dentistry, we also of course need to ascertain that our devices are CE-marked. We got the idea during COVID to check if the instrument was causing spreading aerosols, and this is an experiment we did at Sintef in Norway, which is basically showing you that the use of the brush in a model with green laser doesn't cause, or at least cause very few droplets, very little spread of aerosol. Again, comparing this to the ultrasonic device, which certainly lead to a lot of droplets after an aerosols during use. So at least important during COVID. Might be discussed if this is important now, but from this experiment we at least know that also during COVID the brush was safe to use. We have done our homework when it comes to studies. These are some of them. If you're interested and want to have them sent to you, just talk with Labrida, and they will certainly send you whatever you wish when it comes to our publications. We have a white paper giving you more information about our publications. This is quite early case series when it comes to Labrida BioClean as compared to Labrida BioClean from baseline up to 6 months. We have demonstrated in this study, this multi-center study, significant reduction of both pocket depth and bleeding on probing on patients with mild periodontitis. Pocket depth 4 millimeter or shallower, and bone loss 1 to 2 millimeters. Mild periodontitis, and this is also what the instrument is aimed for. Now, this is how the instrument is used. We'll just show you that very quickly before we jump into some hopefully interesting cases. It's placed or kept in an aluminum pouch, since this is a biomaterial. If you don't keep this brush in an aluminum pouch, it will dry out. So we open the pouch, we soak the brush in sterile water, very importantly, since chitosan swells and becomes soft after seating it in water. So again, all of these videos are on Labrida's homepage. I just wanted to briefly show you what we are doing in the clinical situation, and we also prefer to seat the brush in an oscillating handpiece, looking like this, and we grasp the brush with a tweezer, a forceps, as you can see here, or a plier, and we remove it carefully, not touching the fibers. That's biological material, chitosan, which might be harmed if you touch it. Now it's wet and soaked, and the fibers are quite rigid. It swells about 50%, and you put the brush in sterile water. You may also consider using other chemical detergents. I'll come back to that later in the presentation. Now this is a case of mine, early case. You can see that, and this is a young lady. She has some bleeding around her, one of her implants, 4mm pocket, mucositis, as you can see here. And she even had a fistula. You can't see it on that picture, but she even had a little fistula. At least you clearly see the bleeding after the probing. Mucositis, which is specific, which is exactly what this instrument is aimed for. We want to avoid mucositis around our implants. This patient is a tenacious cleaner, very meticulous cleaner. She has basically no plaque around this implant. She's doing her work with the float, but she still got the bleeding. She even had a fistula when she first came to me. So now you can see what we are doing. We are using the brush in a very light probing moment, letting the brush do the work basically, and we irrigate the pocket with sterile saline. So this is after 4 weeks, which is where we usually like to have our patients to come back at the first active treatment. Maintenance, of course, on a 3-month basis, and you can clearly see that the inflammation is reduced, which is a quite common experience, and what we have also seen in our studies after use of Labrida BioClean on patients with mucositis. This is a 1-year control. She was certainly in on a 3-month basis and expect some bleeding on a 3-month basis. That's completely natural, because this is, again, certainly what relating also to perio patients that we want to maintain them on a 3-month basis. Some bleeding, do the cleaning, but the bleeding is significantly reduced as compared to the baseline situation. No bleeding, no pocket, no treatment. First, check for pockets. If you have bleeding or deep pockets, deep pocket with bleeding, do the work with Labrida BioClean. So 1-year control, no signs of inflammation. The patient has been maintained on a 3-month basis. Now this is another patient, again a young lady. You can clearly see the inflammation. The implant is probably placed a little bit too buccally. She lacks some keratinized mucosa buccal of the implants, which again certainly may add to the problem. You can see the pockets, and you can see the implant. Again, a little gap here. This is a cement-retained superconstruction, not a good thing, but at least we wanted to try to help this patient. As you can see, she has no bone loss, but probably a little bit deeply seated implant, a little bit too buccally placed with lack of keratinized mucosa. As you can see here, we are inserting the brush into the pocket. We with the aim to reduce the biofilm on the implant, and this is a little video showing this. Now you can clearly see the inflammation. You see the pockets. You see the bleeding. So patient certainly quite worried about it. She's bothered by the inflammation. whatever she does. And she again is a meticulous cleaner and really does the work when it comes to her home care. And which we have ascertained before we start our work. Make sure that your patients has an optimal situation when it comes to cleaning. This is of course a bit difficult. As you notice, there's a little bit gap between the implant and the abutment, make it more difficult for her, but she at least tried to do the work. In this case with floss, as you can see here, we insert the brush into the pockets. We work very gentle, stabilize the instrument with a finger rest, and we work thoroughly around the implant for about 2 minutes. And you can clearly see the bleeding due to the inflammation. And this is again some pictures on that, and this is how much it bleeds. Don't worry about that. This is purely due to the inflammation. Irrigate with saline afterwards. And this is the situation again after 4 weeks, minimal signs of inflammation, and the treatment method has worked also on this patient. This is another patient I would like to share with you, since we now also, has the possibility to recommend use of the brush in peri-implantitis surgeries. Now this is a patient referred to me for with a deep pocket, a deep, advanced bone loss around the implant, looking like this, a little bit, what shall we say, angulated implants, making it more difficult for her to clean to the least. But she has this pocket that we need to try to resolve. So this is the surgery, raise the flap, and you can clearly see the defect around the implant. And we are, in this instance, using the brush, combining it with hydrogen peroxide and the brush to make the implant surface as clean as possible. You may believe or may not believe in using hydrogen peroxide. We have an in vitro experiment showing that you remove more bacteria by the use of 3% hydrogen peroxide, done here in Oslo, a publication on it. Will it grow back? Yes, but we like to do as good a work as possible when we have the flap open. So I use hydrogen peroxide, combining that with Labrida BioClean during my periodontitis surgery here, grafting with a xenogenic graft, filling the void between the implant and the defect. Again, in this case, we decided to graft this defect. You may also consider leaving it empty, but I'm still filling my defects with graft material if possible. Certainly, quite often it's not no reason to believe that the grafting will work, but in this case, due to the proximity to the neighboring teeth and so on, we decided to graft this defect, especially in the anterior segment. More of the aesthetic zone, we use a lot of grafting also for our periodontitis surgery. Enough of that. It's time for maintenance. And again, as been stated before during this presentation, also after periodontitis surgery, maintenance is of course of vast importance for long-term success. As you can see, we see the brush in the handpiece, and this is the time of surgery in 2014, 2015, 17 months after surgery, and this is 5.5 years after surgery. The void is to the least filled with graft material, no deep pockets, and if bleeding, we clean the implant with Labrida BioClean. Is this a predictable treatment method? The answer to that is, as you may know, no. This is for Kuru. We certainly try to do our best when it comes to periodontitis surgeries, but still quite unpredictable. The only thing that we might see some predictability is, of course, certainly apically positioned flaps, but that's certainly not. But that's certainly not possible to do at all instances. So we have, as of today, this is 2019, but later consensus reports has also come. There's no evidence to support the superiority of a specific material, product, or membrane in terms of long-term clinical benefits when it comes to periodontitis treatments. But I guess we just have to push on and continue with research since this is such an important issue for our patients. What is all this about? Certainly infection control. This is what we work on a daily basis, helping our patients to accomplish as a good infection control as possible. Before starting implant therapies, after placing the implants, but certainly also after any type of periodontitis surgeries. But that I would like to share some of my knowledge when it comes to non-surgical treatment strategies, both for teeth and implants. This is Gisco studies from 2001, quite old publication in Periodontology 2000. He states non-surgical periodontal therapy is one of the cornerstones in the treatment of periodontitis and the first recommended approach to the control of periodontal infections. Now, I have some cases on this that I would like to share with you. First, just to give you some background, some of the advantages and disadvantages of non-surgical periodontal therapy. Easy to understand, but still we want to write it out. Less mobility than surgery, certainly important for our patients. If we can avoid surgery for our patients, it's certainly good news for our patients. Less cost, less invasive, especially in the aesthetic zone. This is certainly of vast importance to avoid doing surgery. I'm always trying non-surgical treatment methods for the aesthetic zone. Again, relating to that, less risk for gingival recessions in the aesthetic zone, less damage to root surface and tissue. So at least in these areas, non-surgical treatment strategies is of course an important thing to try. Cost effective, if performed on the right indication and if performed well, certainly cost effective. Qualitative non-surgical treatment, scaling and root planning, what else you are doing is certainly the way to go. If you do it right, and use a lot of time, which I've done also, to become skilled in non-surgical treatment. Very important. Access is limited, so certainly when it comes to advanced sites, narrow sites, and so on, it's difficult with visual inspection of roots. In the States, we tried with some, micro cameras, but certainly extremely difficult to get that to work. Now, again, regenerative potential of therapy is also limited, even if there are some examples, and I'll show you some of that later in this presentation, where we actually accomplish regeneration after also non-surgical treatment strategies. This is, again, the EFP clinical practice guidelines, and Suvan and co-workers in a systematic review demonstrates that non-surgical periodontal therapy by mechanical subgingival instrumentation is an efficacious means to achieve infection control in periodontitis patients. Important to keep this in mind when you discuss with the patients. It's important to start the causative treatment phase prior to doing surgery. Very few patients that I treat are not treated in a non-surgical treatment phase prior to surgery, and that also reduces the number of surgery we do now in these days as compared to when I started working as a periodontist many years ago. Now we give it a longer time prior to doing surgeries. We wait for the healing 6 months, sometimes up to 2 years after the early phases, and we certainly by that have reduced the number of surgeries dramatically. So to be patient is certainly important after the non-surgical phase. Average pocket depth reduction, this might be important to remember, especially for the hygienist here today. 6 to 8 months after healing will be 1.4 millimeters. Certainly varies from one rooted teeth, multi-rooted teeth, and so on and so forth. But as some kind of rule, 1.4 millimeter, 1.5 millimeter. So that might be something to aim for, at least. But certainly sometimes we see way more than that of reduction. So by that, let me share you a study undertaken by one of my PhD students, Badra Hussein, whom I share with Professor Håvard Josten Haugen. Badra, she was the leading author for this study. She also had the possibility to do a study, a multi-center study, together with Professor Bahari and Kuru down at Yeditepe University. So we were really happy to get the chance to undertake this study in two centers, University of Oslo and Yeditepe in Istanbul. So now what Badra is doing in this study, she's comparing regular curettes with Labrida BioClean. Certainly interesting, since we had gotten anecdotal information that Labrida BioClean also may work for teeth. So prior to putting this in the hands of our friends and peers, we certainly wanted to check if this was that this could be recommended. So the group treated patients between 5 and 7 millimeters, and all the patients had been actively treated previously. They had remaining pockets, and the study was randomized, examiner blinded, and we checked the patients after 6 months. So this is the result, and again, this is basically what we are doing. This is the result of the situation, using the brush, putting the brush in sterile saline, inserting it in the pockets, and irrigating the pockets after use of the brush with sterile saline, as compared to curettes. So in the sites where we used Labrida BioClean, the Labrida BioClean was used, curettes were not used. So either curettes or Labrida BioClean, and the reduction in BOP and PPD were used in both test and control group, but we had a significantly better reduction in pocket depth at 6 months in the test group as compared to the control group. So this is the conclusion, and Badra will defend her thesis the 5th of June. So we're much looking forward to that. This study has been published, and if you would like to have an PDF of it, just let us know. Now, combining the brush with chemical detergents is certainly also, or with chemicals, is certainly also interesting. We, as many of you have certainly read the publication by Filippo Graziani, doing non-surgical treatment with or flapless treatment with enamel with EMD, Emdogain. So he followed patients treated with scaling and root planning plus minus Emdogain up to 3 months after active treatment, pocket depth 6 millimeters or deeper, and he treated 38 periodontitis patients with scaling root planning plus minus Emdogain. So obviously an interesting publication, especially for our patients with deep pockets in the static zone. Now this is basically what he's doing. He's doing scaling and root planning, and he cleans the pockets with Prefiel, a standard procedure of Straumann. Now of course injects Emdogain into the pockets. He managed to demonstrate that at least in the anterior segments he had significantly better reduction when he combined scaling and root planning with Emdogain up to 3 months after treatments. Short study, but still certainly proof of principle. May work in some cases, and I think it's worthwhile considering such a procedure in the anterior segment. Now, these are 2 of my patients, and they are treated either surgically with Emdogain, 2014. You can see the baseline for the patient on your left-hand side as compared to the patient on the right-hand side, 2021 patient. Both of them are quite similar when it comes to pocket depth, close to 7 millimeter pocket depth with bleeding. These are the radiographs. The 2021 patient had been treated surgically prior to us trying, the flapless treatment with Emdogain. So this is the surgery on your right-hand side, just to compare two strategies for such defects. Very narrow defect, difficult to clean out, but still, close to a 7 millimeter intraosseous defect. We use Prefiel. This is the first patient in this little presentation when it comes to Emdogain, the surgical method. And as you can see here, irrigate with sterile saline, and we apply Emdogain into the pocket. Very simple, very standard procedure. I've done these procedures since 1997. So on the right indication, this is something that certainly may work. Now, this is the simple suturing, one suture done, as compared to the patient on the right-hand side, which is has, where we have undertaken scaling and root planning, removal of some calculus. We apply Prefiel, and we use the brush, the Labrida BioClean, to debride the root surface with Prefiel. I'll come back to that a bit later. And we insert a gauze, very similar to the method used in the flapless procedure by Filippo Graziani, but in this case, we use Labrida BioClean for the debridement. If no calculus, avoid using a metal instrument, the curette, purely use Labrida BioClean. That's what I'm doing at my cases to release. Now you insert the gauze just to open the pocket. Could also certainly, as a clinical advice, be tip be used also during conventional scaling and root planning. And the pocket is, due to this open, avoid to have as little bleeding as possible on the root surface. Get as clean as possible through saline and this gauze, and we apply Emdogain starting from the bottom of the pocket. So very trivial. Takes about 5 minutes as compared to the surgery, which is 45 minutes, an hour, something like that. So certainly very also convenient for the patient, and certainly a very limited cost as compared to the surgery. So in that anterior segment, this is something that I use quite often, trying to avoid surgeries, trying to get recessions and so on and so forth, especially in the aesthetic zone, is definitely worthwhile trying. I find it. Now let me show you what we did one more time. You can remember now that this patient had been treated with surgery before, and we still had the remaining pocket. So what should we say? A little bit of a disappointment when it comes to the low success of previous treatment. So this is just to show you what we're doing, applying Prefiel into the pocket, Strama Prefiel, leaving that for 2 minutes, combining it with Labrida BioClean, as you can see here, wet brush, applying it into the pocket. And we work, this is just certainly just to show you how we work the brush, a very gentle method. No risk for leaving any filaments in the pockets, and we certainly try to avoid damage to the root surface in the, as much as possible. So now cleaning of the pockets and irrigating, putting more Prefiel into the pockets, and we clean the pocket with Emdogain, with the Prefiel and the brush and Labrida BioClean. So gentle work and stabilizing the handpiece on a neighboring tooth, really working our way into the pockets. Not pushing the brush into the pocket, but just letting the brush do the work. Now here again, irrigating with sterile saline. Very important to remove all the Prefiel. We don't want to leave any Prefiel in the pocket at all. It will not resorb. That's of vast importance. So, thorough cleaning, one full syringe of sterile saline. Especially important when we perform a non or a flapless Emdogain treatment to remove as much as possible of the prefiel. Now inserting the gauze into the pocket, and we remove it, and we immediately apply Emdogain into the site. So this is the method, and the pocket is reduced from 7 millimeter to 3 millimeter. Again, remember that this pocket had been treated before, prior to trying this non-surgical method. So one of many cases that we have used this method on, and at least worthwhile trying in the anterior segment to avoid surgeries. The less surgeries, of course, certainly the better for the patients. Now this is the 1-year control, and 2015 for the patient on the left side, and 2022 for our non-surgical or flapless treatment on the right side. As you can see both of them with different strategies got a remaining pocket of about 3 millimeter with bleeding, so a stable situation. 10 years control on the left side and 3 years on the right side. 2024, a little bit more pocket on the right side after the surgery, and we certainly decide to perform maintenance with Labrida BioClean on that patient. Now, based on this, and I also told you that I was going to say a few words about non-surgical treatment of peri-implantitis, and this is a recent publication from my colleague Dr. Roy Samuelsson. What he has done, and what really intrigued him close to 10 years ago, was trying to develop methods for non-surgical treatment of peri-implantitis, which to some people might sound a little bit obscure, because by convention it's been said that surgery should always be performed on peri-implantitis. But after this publication, and after what he had done, and now other clinicians also throughout Europe, you may to some extent at least discuss non-surgical treatment strategies for peri-implantitis. Certainly an aggressive situation peri-implantitis is, but so I mean the more we see of this disease, we realize that we need to find easier methods to treat the disease. Now let me show you one case of Labrida BioClean combined with hydrogen peroxide and tetracycline slurry. I'm going to jump really quick to this one. I'm going to show you the method in a more extensive fashion quite soon. But basically, just to give you an overview, this is a patient with very advanced peri-implantitis around an implant, deeply seated and all of that. As you can see, screw retained. Luckily, we managed to remove the implant crown quite easily. And as you can see, very deep pockets, very advanced disease. Now, let me go over this in more thoroughly. Now, this is certainly a method involving antibiotics, which is certainly not something that should be at least tried to be avoided. A no-go product is quite a clear statement. Antibiotics here. So let's see if we can find another method avoiding antibiotics for doing the same work. Now, this is just a background. This is basically what Roy Samuelsson did in his publication, his case series on 24 patients showing very positive results, even some bone fill around those implants. So please contact us if you want to read the full publication. A case series, again, 24 patients, not an RCT, but certainly interesting from a perspective of at least attempts to try to avoid surgical treatment of peri-implantitis. Now, this is the baseline. As you can see, patient referred to me with, very deep pockets around the implant, bleeding, and certainly a worried colleague. So this is what it looks like. As you can see, advanced peri-implantitis around these implants. By many could probably consider to be lost. The problem with this site is the narrow defects, certainly, and also, of course, the proximity to neighboring tooth. So this makes it certainly more difficult, also from a surgical standpoint, to clean these implants. So the brush if surgery would be considered, the brush is certainly also an alternative to make the implant surface cleaner. Now, this is hydrogen peroxide on the brush, which is the first phase of the treatment. Again, remember now that this is purely a flapless treatment strategy. This is irrigation with sterile saline after 2 minutes of debridement with hydrogen peroxide, 3% hydrogen peroxide, and then this tetracycline slurry, which my colleague had, developed. So you can read more about this in our publication, in his publication. Again, entrenching the brush into the tetracycline, and now using the brush as a carrier for tetracycline, and again inserting the brush with tetracycline in the pocket. It looks quite dramatic, but again repeated after 2 weeks, which was Dr. Samuelsson's protocol for the procedure. So as compared to medical doctors, us dentists have a tendency to just doing one-hit wonders. We do the treatment and we wait for 3 months, whereas the doctors quite often do the cleaning, and then they continue repeatedly to clean until they see result. So this is what Roy wanted to try also. He gave it 2 weeks and he saw some response, and then he cleaned again, and he did the same thing after another 2 weeks. So 3 times he cleaned the patients with periodontitis, advanced sites, and this after 3 years. Now the patient had also been at the clinic on a 3-month basis. If some bleeding, we certainly use Labrida BioClean for the cleaning. And this is again, as you can see, no inflammation, no surgery has been done. This is purely Labrida BioClean with this Samuelsson protocol. As you can see here, minimal pocket depth after 3 years. And again, same crown. We haven't changed anything except for doing this treatment, and certainly also importantly the maintenance. This is baseline, as you can see, with advanced disease, advanced bone loss. The implant is on the way of getting lost, certainly, and this is after 3 years. No pockets, and the defect is to the least filled with some mineralized tissue, hopefully bone. Looks like we have a reosseointegration, but it's certainly difficult to judge, or impossible to judge without histology. So this is what it looks like after 3 years. So certainly a positive result. And Roy has seen the same thing on 24 patients. Just feel free to contact Labrida if you want that publication, Samuelsson and co-workers. Now, this is Labrida Helix. Since I mentioned that you certainly want to try to avoid using the use of antibiotics, in many countries banned. I think that also goes for Sweden. Now, Labrida Helix is the same, a little bit close to the same pH, because I believe that much of this response is due to the low pH of tetracycline. Probably not the antibiotic effects, but in my mind, my thought, and after thoroughly looking into the literature, tetracycline certainly has a low pH. I took the time and measured pH both in tetracycline and other chemical detergents used within dentistry, and Labrida decided to start to develop a gel with the same low pH to see if we manage to get the same results. So this is Labrida Helix, which is a chitosan lactic acid gel, which we in this case entrench the brush to try to mimic the method where tetracycline is used. Now, this is again, of course, certainly Badra Hussein's study where we use the brush for non-surgical treatment of periodontitis patients, which I've showed you before. The good news with chitosan is that it's bacteriostatic, biocompatible, and anti-inflammatory. So we decided to again try to see if we could do some good with a chitosan gel instead of just using the brush, if we could enhance the effect of purely using the brush. Now, this is the control group on the left-hand side. As you can see, this is a little experiment done at University of Oslo, Department of Microbiology, where we compare titanium coins with growth of Porphyromonas gingivalis. As you can see here, on your left-hand side, we have 7 days of growth of PG, whereas on the right-hand side, we have Porphyromonas gingivalis with after cleaning with the brush and Labrida ilex. The lactic acid gel is pH 3.86, so a low acidity. Now, this is the method. Basically, as you can see, comparable to what I've showed you previously with the Emdogain, non-flapless treatment with Emdogain, and this is the bleeding. Quite advanced site with bleeding or probing. Again, we entrench the brush into Labrida ilex, the calcium lactic acid gel with low pH for about 2 minutes, and then we clean the site with Labrida ilex for about 2 minutes. And this is a typical patient in the study that we have recently finished here in Oslo in the group. And as you can see here, we irrigate the site with sterile saline, and we do exactly the same thing as we did for Emdogain flapless. We insert sterile gauze into the pocket, wet the sterile gauze to open the site and remove as much blood as possible, and we inject Labrida ilex into the pocket and leave that in place. So my PhD student Ole Klein has done this in 20 patients, and comparing that to 20 patients with purely the use of Labrida BioClean. This is the study where we just recently finished a 12-month control. This is Dr. Maria Balta, also associate professor here in Oslo, and our PhD student, our fellow PhD student Ole Klein, doing this study. More than 540 sites were treated in this study. We present the study at EFP at the poster. Now, this is the study, and as you can see here on the left side, he cleaned the sites with Labrida BioClean with ilex as compared to the right side where Labrida BioClean alone is used, and then thereafter irrigated with saline. And again, on the left side, you see the test group with the ilex inserted in the pocket. Exactly the same method I showed you just previously. 20 patients each group, 3 to 8 sites, pockets up to 8 millimeter in depth with bleeding or probing grade 2 or higher. Now, this is the conclusion. Both treatments led to significantly less sites with inflammation after 4 weeks and 3 months after treatment. So both methods work to some extent. We had a reduction in pocket depth and bleeding, both with Labrida BioClean and Labrida BioClean combined with ilex. But with adjunct Labrida ilex, we had significantly less inflammation, both with regards bleeding or probing. We also had less pockets, and we also he also demonstrated that we had significantly better reduction in teeth with teeth needing active treatment than Labrida BioClean alone. So this is a short overview of this study, hopefully soon to be published. It's submitted for publication, and it will also be presented in the form of a poster at the EFP meeting next week. So maintenance is of vast importance. We all know that. I would like to conclude my presentation with a short little video from colleagues around Europe. So remember now that keep in mind, this is the main message of mine: infection control and maintenance. All your implant patients will need some extent of maintenance, whether you decide to use Labrida BioClean or other methods, but the message is clear. Maintenance is of vast importance. We all know this. We know it. Japan, we know it. Spain, we know it. Serbia, we know it. Ja. Sunnmörsk. Turkisk. Grekisk. Svensk, jag vet det. Tysk. Spansk. Italiensk. Maintenance is important. A little bit proud of that video, the power of maintenance. So by that, we hope to see you next week. Labrida is also going to to Vienna for the AFP meeting next week. We thank you so much for your presentation. Please, if you have time and want to chat more with us, discuss things, come with input, or ask us questions, or meet us, please come to our booth. CEO Anne Kristoffersen will be there. I'll also be there as much as I have time for. And I really hope to see you and talk with you, and eager to get your questions now and your input either now or next week in Vienna. Thank you so much.